Hey guys, so I recorded a whole video before this and like two other like practice things just because, and I ended up getting interrupted in the last one, but which was fine, but I said a couple of things that were wrong. I said a couple of things that didn't sound the best, and honestly, I'm very much a perfectionist. So I'm glad that at least for this session, I just because I haven't been able to review it that much, I'm glad that I'm doing a recording just because I can watch what I say a little bit better. And I really just don't want to give you guys bad information. And I feel so bad sometimes because I feel like I'm not the best explainer. I feel like I'm a little bit better when I review this information. So I'm gonna be honest. At least for the renal stuff, I do not remember a lot of this stuff. I'm kind of going to be reading more of it. I won't be reviewing every single little thing, but I will be at least reading it so you can kind of follow with me and then just kind of giving you some questions in terms of the renal pop quiz that you'll see right there. So, um, for the electrolyte imbalances, for the acidosis state, and alkalosis state, and before I start going in, I almost forgot. Um, so I ended up getting sick. So I ended up staying home from clinic today. I'll have to tell you guys about it if we have a next Zoom meeting, in which I also have to see how that goes because I have a wedding that's coming up for one of my family members. I have a lot of exams coming up, and obviously with missing school, because I don't know when I'm allowed to go back to school, basically. So it's up in the air. They said that they would let me know, but even I don't know yet. So we'll see what happens. But basically, what I would just say is I'll let you guys know probably last minute. So I thank you guys for your patience. But one thing that I did learn is that I feel like as nursing students, we prioritize school. I think one of the biggest things I was worried about was I'm more concerned about, I was telling my doctor, I'm more concerned about not missing school. Like I don't want to miss school rather than me being sick. And I literally felt like I was dying. And I am kind of a pansy when I'm sick, but I kind of was like, I feel like I'm dying, but at the same time, I really want to. I need to go to school. I even said like I don't have a choice. Like I need to go. And even though I had to remake a day up, and it's so funny, I've been so unproductive this whole day. But that is, I'm sick. But and I was even thinking, even if I wasn't sick, you should still be able to prioritize your own health. If you want to go to the gym, you should be able to go. If you want to spend time with your kids, if you want to spend time by yourself, if you want to be scrolling on TikTok for like an hour, like you should be able to kind of do that, on your own. And of course, you prioritize studying, you do all of that. But I think as nursing students, we feel really guilty about, we should be studying all the time. We should be doing this. I'm so behind. I have so much things to do. But treat yourself, and you don't even have to feel about like you're treating yourself. This is just taking care of yourself because we're always on the go, we're always on the run. So I just hope you guys are able to know, like, even though I am sick and you're like, okay, well, you should be resting, you should be kind of doing things that are unproductive. It's like myself, I tell myself, no, like I should have been studying, I should have been doing all these things. I could have recorded this a lot earlier. Um, Hope you guys take some time for yourself and everything like that. Also just really want to quickly touch on OB midterm. A couple of people reached out saying they didn't do their best sis, which is okay. I'm gonna be honest, I did. Let's just say that for the OB midterm, I did not pass it until she regraded it, and I do know a lot of my peers also did not pass it even after she regraded it. We all ended up passing the class. The final I felt like was a lot easier than the I'm sorry, I'm gonna be drinking like my water throughout this. Um, the final was a lot easier, I think, than the midterm, but I don't think that. I think it also was because we were already like 8 weeks in, whereas when you're 4 weeks in, you feel like you're still learning a lot of this information. So I would just say, um, if you're struggling, what my recommendations for you guys are is to watch her lecture videos after she gives a lecture. I ended up doing it like a couple days before the final, and I kind of did it, if I'm gonna be honest, probably like 24 hours before the final, like the day before. I watched all of her lectures with the guided notes. I did rewatch the medication lecture. I rewatched the fetal monitoring, and I felt pretty good about fetal monitoring. The meds, I feel like I did not have down until days before the final, if not before the final. Um, and I did not feel great about like the questions and the risk factors. So I feel like watching all of the her like lecture videos again was super helpful. But she has a practice test on Canvas, or a quiz, and it might give you a grade, but it's like it's not going to actually go into your grade book, like nothing's affected. So I would recommend to do that as many times as you can, because it gives you rationales, and keep doing it. And I would do it to the point where it's like I would basically know the answers, but you're not memorizing the answers. I would go through and be like, this is the answer because of this, like this is makes sense, or try to think about it in a way where like even if it's not necessarily the 100% right rationale, what's the way that you think about it? Like you don't necessarily have to give an answer, but it's like this is how I think about it, which is still your own sort of rationale, right? And I feel like that's because I was on a time crunch and I was like, the day before, like let me try to do this, and I felt like I was very successful on the final, but I didn't translate that onto the midterm. So I would recommend to watch her lectures for sure after you go through it in class, because I know she skips over some stuff. So I know that like your time is your time. So even I was like, oh, why do I have to watch another thing? Like I don't have like I have to work, like I have to do all these things. I understand that, but it really will become helpful. And at least make sure or try to do that before the final if you're not understanding some of that information that's being said. Um, and then really I would just try to just focus on your medications. You should be able to tell me those symptoms that are important, those contraindications that are important, stuff like that. So you don't have to know every single thing, but just make sure you're knowing the things that she points out, because those things are super important to know. Um, so yeah, try to solidify those medications so by the time the final gets down, you're good. Again, try to solidify those fetal monitoring things, just because you want to be able to get that down and just kind of review it for a quick second, make sure okay, I still got it for the final. So hopefully that covers some things up with that. So I think there's one more thing actually. Peds people, hope everything's going good. I would say for the final, just be focusing on things like developmental stages, ages, behavioral changes in terms of like Piaget's, all that, Erickson's. I think she asks like some things about that, but I think that's probably one of the harder things. And just like the questions about like if they're a toddler, what are they expected to do? If they're 12 months, can they walk? Or how many words are they able to say? Things like that. Like what are the expectations or things that we should be seeing from age groups? I would feel like those are the hardest things to get down. So try to look at ATI, because she kind of follows the same thing, and they will be on your ATI proctored as well. Yeah, but other than that, let's get into it. So for acidosis states, remember we're looking at more of symptoms that kind of have depressive symptoms. So like a weakness, and disorientation, whereas with alkalosis states, we're kind of looking at more hyperactive signs and symptoms, so like spasms and convulsions. You guys don't need to know SaO2, but know that basically we're looking at the arterial oxygen saturation. So for SpO2, that's basically the same exact thing as SaO2. The only difference is one of them's more invasive and the other one's not. So SpO2, we're literally sticking it on their finger, right? And we're just getting their SAT. It basically tells us, but the SaO2, we actually have to take a blood draw. We actually have to see what's going on, and that's more specific and that's more, that's more accurate. But basically they're the same thing. With PaO2, this is just the partial pressure of O2 dissolved in the arterial blood. So this can differ, right? Because we know that when our patients, and again, this kind of goes into fourth semester stuff, but again, it's really not that hard to understand. Just how much oxygenation are they getting, which again, you don't really need to know. And then pH, CO2, HCO3, you guys know that already. With BE, you don't really need to know that. I feel like they never go through that. And in fourth, they definitely don't go through that as well. So I won't be going over like every single thing here in terms of the signs and symptoms, just because they focus a little bit more on the compensation side of stuff, and just if you're able to interpret it, as well as I feel like they'll point out a specific scenario and you just have to point out like which one are they going to be in. And it's not necessarily like if they're septic, it's kind of like if they're choking on something or if they're having like an anxiety attack. So I feel like those are more sepsis related or respiratory related. So with metabolic acidosis, you're looking at a pH that's below the normal range. So let me see that if I can pull it up right here. So I'm just going to talk about it in terms of a compensation way. So 7.35, you're looking at it being below the normal limit. So it's going to be in an acid state. So in first semester and second semester, you just saw that one of the values was within the normal limits, and now the other one was out of the normal limits. Well, now you're looking at where both of them are out of normal limits. So how do you determine which one's which? Well, basically, the one that matches the pH is what's causing the pH to happen, right? So that makes sense. So if you're looking at the HCO3, which we know is what? A base. So if you're having less base, you're in, right? We're having less base. We know that you're in an acid state. So what's causing your pH to be in an acid state? Your HCO3, which is the renal system, which is your metabolic system, right? So you know that you're in a metabolic acidosis state. So that's basically how I interpret it myself when I'm going through an exam. And Mandiola gives us like 1 minute to be able to do these. And it's crazy because you add on a little bit more, but so it can be stressful. But just think about it that way. Like, what is matching that pH? If you feel like you just have to be like, okay, let's go. But it makes sense, right? So with PCO2, so PaCO2, we know that this is a acid. So in this specific setting, what's going to happen is your metabolic system and your respiratory system, what's going to happen is they're going to compensate for one another. So we know that the renal system is doing things more slowly because, again, those are your kidneys. They need to retain and excrete things, but that takes a longer process. Whereas your respiratory system, they can just hyperventilate, hypoventilate to get rid of that CO2. So if I'm in an acidotic state, and we know that CO2 is an acid, okay, do we want a higher CO2 or do we want a lower CO2? So take some time to think about that. Okay, so hopefully your answer was is that we want a lower acidotic state, meaning we want lower CO2 levels. Okay, so for this type of question, you probably would also see a CO2 below the normal limit. So you might see it as like a 30. So again, how would I interpret this if I saw like this specific set of values? Well, again, this is an acidotic state. I know that because it's within, it's below the normal limit. I know that HCO3 is a base, so we're having less base, which means I'm in an acidotic state. And then I know that PCO2, PaCO2 is an acid, and I know that it's low, so that means it's in an alkalotic state. So this one is matching this one, meaning that my HCO3, my bicarb, is causing my pH to be low. So we're going to be knowing that this is a metabolic acidosis state. And then I know that my CO2, as in my respiratory system, is compensating because it's trying to get this acidic state into being an alkalotic state, or not an alkalotic state, but necessarily is trying to get the acidity to be less so that it can become more neutral and more base. So because of that, it's going to be partially compensated because my body has partially compensated to deal with all of this acidity that my HCO3 is causing. So basically what's happening here, my kidneys aren't retaining that bicarb. So they're letting go of all that bicarb. They're not retaining it more of, so they're just not retaining that bicarb, which causes me to have more acidity. So it's a metabolic issue. So what's going to happen is my respiratory system is going to go ahead and also decrease CO2 so that my pH can have less of an acid state with the PCO2, so it can kind of go a little bit higher. But it's not fully compensated because my pH isn't fixed yet, right? It's partially compensated because the other system's compensating, but I'm not fully compensated because my pH hasn't gone within normal values. And the thing is, those you can be fully compensated and have the other values still out of range. So you're fully compensated whenever you have those ranges within normal limits. So yeah. Another question. So let's erase this. Let's erase this and act like, again, we want negative. We want lower CO2 levels, right? Because it's an acid. So with that being said, are we going to be seeing hypoventilation? Are we going to be seeing hyperventilation as a compensation technique or mechanism? So hopefully your answer was that we want to be having hyperventilation, right? Because keep in mind when you're, it takes me a second to think about it because for a second I'm like, wait, so we're gonna be having hyperventilation because if I'm breathing out, right, like I'm getting rid of all of that CO2, so I have less CO2 that I'm retaining. Whereas if let's say I am hypoventilating. So meaning I'm having a lower respiratory rate. So I'm holding on to my, I'm holding my breath, meaning I'm having all of that CO2 stay in me, right? I'm not getting rid of that CO2. So remember with the respiratory system, you're having gas exchange of your oxygen and your CO2. So we want to be able to exchange that. But if I'm keeping all that CO2 with hypoventilating, I'm having higher CO2, right? Whereas if I'm hyperventilating, getting rid of all that CO2 on the way out, getting having that being excreted, meaning I'm having higher or lower levels of CO2 in my blood system. So you're going to be seeing hyperventilation in that in terms of a compensation rate. And so just remember when we're talking about causes, we're not talking about, I understand how, like, let's say with sepsis. I think for our exam recently, she had asked us if, like, what are some of the causes, or not causes, but like, what are, maybe she did say that. Like, what are causes seen with like respiratory alkalosis? And sepsis was one of our answers, I think, for that. I'm trying to remember like how the question was worded. Yes. So respiratory alkalosis was the thing, a question. And one of our answers was like sepsis, anxiety, things like that. And so some people put sepsis because technically with sepsis, the compensation is that you're going to be hyperventilating, meaning you want to get rid of that CO2, meaning you're like having a respiratory alkalotic state with hyperventilation. But remember, like, that's your compensation method that's happening. If the question was like, as a compensation method, how would you, how, what state would your acid basic balance be with like sepsis? That the answer would be respiratory alkalosis, right? But that's a compensation method that it's doing because you're in metabolic acidosis, right? So remember, like, it's not like the hyperventilation that's coming from there, and that can cause like respiratory alkalosis, but that's basically trying to, the reason why it's doing that is because your respiratory system is trying to have you excrete all that CO2 because you're hyperventilating. But if the issue that's coming, that's causing your pH to be affected is your metabolic system, right? So, and she had explained that, like, remember, sepsis is a metabolic issue, it's not a respiratory issue. Like, your compensation method is going to be respiratory alkalosis, but it's not going to be the actual cause of what's driving your pH to be low. Does that make sense? Hopefully that makes sense to everybody. So if the question is like, what's causing this to be low? Because I understand when we talk about compensation, because you guys are now bringing this into this stuff, just know that you're dealing with metabolic and respiratory. So with compensation, you can have different types of compensation that are happening, right, in response. So like in difference to metabolic acidosis, you're going to be having respiratory alkalosis with hyperventilation as a compensation method because you have metabolic acidosis in the first place. But you still are in metabolic acidosis. Like, the cause is metabolic acidosis. Like, that's what's causing you to basically hyperventilate. So the cause is metabolic acidosis. What is driving the pH to be affected? So causes, again, sepsis, because again, like, think about it, the lactic acidosis. So lactic acid is high. DKA, we all know that. Just make sure for Kussmaul's respirations, and I'll put this on the exam review next week. You're seeing deep and rapid respirations. That is what Kussmaul's respirations are. And I'll probably go through the different types with you, just so you know that, as well as you know that going into fourth as well. Then you have diarrhea. And again, diarrhea is a part of metabolic acidosis, right? So that little like term acronym that we use. And then also, if you think about it, you're getting rid of all of that base that's happening with diarrhea. Renal failure, because again, they're not able to retain all of that bicarb. Aspirin overdose. And the reason why it's with aspirin is because if you think about like the like the name of aspirin, I always get it confused, but I think it's what, acetylsalicylic acid. That's the entire name of aspirin, right? So I think that's what it is. But it has acid in it. So acid, right, and affects your kidneys. That's kind of how I think about it. So, and then acidic drugs, which makes sense because again, drugs metabolized in your kidneys, acidity, there you go. And it's not really a respiratory issue either. So signs and symptoms: headache, lethargy, diarrhea, coma, death, nausea, vomiting. Makes sense because we're talking about like aspirin overdose, acidic drugs. We're talking about like DKA. Again, we said diarrhea, renal failure. And then again, we're going to have more of those depressive symptoms that we see there. So for IV lactate solution, what we're talking about is like lactated ringers. So know that lactated ringers can become bicarb basically through the liver, I believe. And so we can give bicarb because obviously we're not having a lot of bicarb, so we can give that. So as a result, going into metabolic alkalosis, basically this is an increase in base. You're having too much base. So let's say if I'm giving a septic patient bicarb, right? Because they're not having any bicarb. I give them bicarb, so I give them lactated ringers. That becomes bicarb through the liver. So now I have too much bicarb. I give them too much bicarb. So now what kind of state are they going to be in? They're going to be in a metabolic alkalotic state because now they have high bicarb. So other causes loss of GI fluids. That makes sense because think about like when you have GERD, when you're vomiting, which is another cause. If you're thinking about vomiting or like things with GI fluids, we're talking about those fluids come up. So like whenever you're vomiting, I hate throwing up. I refuse to do it. When you're having vomiting, you can kind of feel the burn in your throat, right? Because of all the acidity that happens. It feels absolutely disgusting. So when you're having that, just think about that. Like you have that acid, now you vomited all that up. All that acid is gone. So now you're more in a base state. NG suction, same thing with that. And then hypokalemia. So potassium is like an acid essentially, right? So basically, if you're having loss of potassium, you're having loss of that acid. And then those are the other stuff, but I feel like they're not going to ask that information from that. So as a result, we're talking about metabolic alkalosis. What's the system that's going to be compensating? The respiratory, right? Because we only have two, and it's going to be the other one. So we know that the pH is going to be high, so that's going to be in an alkalotic state. And then we know that I got confused. We know that the bicarb is going to be high because we know that it's a base. So it is also in an alkalotic state, meaning that this is driving up the pH, meaning that we are in a metabolic alkalosis state. So now when talking about compensation, we got rid of the within normal limits in first and second and third semester. That's first and second semester. So we're moving up. So this is now going to be, let's say, we know it's 35 to 45. So this, let's say it's going to be 47. So this is now, when looking at this, it's like, okay, this is an acid, right? So basically what's going to happen is that your CO2 is going to go higher because remember, CO2 is an acid and we want more acid. So we want the patient's body to be able to compensate, or their respiratory system to compensate and be able to increase the CO2 that's they're retaining in their blood because they're already in an alkalotic state and the other system has to compensate from that. So we know that this would be, when looking at 47, if that was our value, it would be partially compensated because your respiratory system has now gone within normal limits so that it can then go ahead and help with the pH, bring it back down into more of a neutral state by adding some acidity to that. So it would be partially compensated metabolic alkalosis, right? So now when looking at this, I kind of gave you guys the answer, but so we want an increased CO2, right? Because we want more acid. We know CO2 is an acid. So if we want more acid and we want more basically CO2, am I going to be hypoventilating or am I going to be hyperventilating? So essentially, you only really have to memorize one, right? Like if you memorize the metabolic acidosis one, then you have the answer for the metabolic alkalosis one. So the one we did earlier, so if you remember that one, of course, you're going to be like, oh, I know what the next answer is, but you have to be able to explain it to me, right? So the answer, hopefully, is going to be hypoventilation, right? So if you think about it again, like if it takes you a second, like same, it takes me a second. I literally have to think about it like for like 2 seconds. So if I'm hyperventilating, getting rid of all that CO2 because that's the gas exchange, getting rid of excreting it out because we don't want it within the body. It's a waste product. It needs to be taken out. So I'm getting rid of that CO2. If I'm hypoventilating, meaning I'm not breathing, right? So that means that I'm retaining all that CO2. That CO2 is not coming out. So I'm having all that CO2. So if I'm in a metabolic alkalosis state, meaning I'm having high base, I want more CO2. As a compensation method, your respiratory system is going to go ahead and hypoventilate, meaning decreasing the respiratory rate so I can keep more of that CO2 in me. So I hope that makes sense for that. And let's move on to the very next thing. And then again, for the signs and symptoms, just to explain that, the respiration slow and shallow, right? You're going to see that as kind of more of a compensation method that's happening because of the hypoventilation that we want because we want to retain the CO2. Hyperactive reflexes, right? Because we're talking about alkalosis. Tetany, which again has to deal with your convulsions, often related to depletion of electrolytes. Yeah, so what? Loss of potassium. So what are we going to do to fix that? You can give them potassium, give them chloride, and then figure out what's the cause. So if you're suctioning them too much, maybe suction them a little bit less. Are they vomiting? Maybe go ahead and give them nausea medication, anything like that, an antiemetic medication as well. Let me go ahead and erase this. Okay. Now moving on to respiratory acidosis. So the renal system compensates slowly because, again, it has to retain and excrete, whereas with your respiratory system, it can do that a lot faster by just hyperventilating. So with respiratory acidosis, you're going to see your SpO2 be down because, again, it's going to be down with acidity. It's going to be up with alkalosis. Getting rid of this because we're not in first and second semester anymore. And then 45, going to be above the 45 value because, again, it's in an acidotic state, meaning that we're going to be hypoventilating, right? And again, I had to take a second for me to think about it. We're going to be hypoventilating at this point because I'm retaining all of that CO2. So if I'm hypoventilating your patient, maybe they had a head injury, maybe that you gave them too much pain medication, which hopefully isn't the case, but maybe you gave them too much pain medication, maybe they have COPD, they're not able to breathe out as much, and having less gas exchange, so they're not able to let go of that CO2 more effectively. Maybe they're having breakdown of their alveoli, anything like that. And we'll talk about that with respiratory alkalosis as well. So whenever you're looking at this, now we know that this is a respiratory acidosis state. So now when we're talking about bicarb, so we know that bicarb is a base. So if I'm in an acidotic state, would I want more base? Yes, right? So that means I would want more bicarb. So I want more bicarb. So basically, we know it's 22 to 26. So let's say if the problem was saying it's below 7.35, above 45, and now I have high, let's say like 28. So if I had 28 as my bicarb, I know that at least it's out of normal range, so it's partially compensated because I'm not fully compensated because this isn't fixed yet. But I still know that this CO2 is driving my pH to be acidic, so I know it's going to be partially compensated respiratory acidosis. So yeah, I basically want more base, meaning that my kidneys are going to retain more of that bicarb. And so again, the causes CNS depression. So if I get a head injury, anything like that, oversedation, trauma. So if they get hit anywhere, they're not able to have that proper gas exchange, so they're hypoventilating. So basically, these are all hypoventilating things, right? So hypoventilating can be a compensation method with the metabolic stuff, but remember that also what is the cause of that's causing the pH to be affected. And then COPD, pulmonary edema, pneumothorax, those are all having to impair gas exchange. And then that can be helped with a BiPAP, which changes in when it has different pressures, right? Because Bi has different pressures, whereas CPAP has a continuous pressure, has different pressures, but it allows for easier gas exchange of CO2 and O2. So signs and symptoms, basically, you see all of those hyperactive states. So breathlessness, and again, those have to do with more respiratory things, right? Breathlessness, restlessness, convulsions, you see that again, tremors, coma, a respiratory rate rapid, then gradually depressed, right? Because eventually they're going to be hypoventilating. Their skin is warm. So things that you see with hypoventilation, basically. And then you're going to restore ventilation. So again, you can put them on a BiPAP. If they are hypoventilating, what are you going to do if they stop breathing, right? We're going to call a code on them, like a rapid. You're going to intubate them. IV lactic solution, again, so they're having this, even though it's a CO2 problem, you still can give them lactic solution so that they can go ahead and basically become bicarb so that they can have and compensate for that acidotic state. And then again, you want to see what's the cause. Are you giving them too much pain medication? Don't give them pain medication. Respiratory alkalosis, going into that one. So this one is a hyperventilation state, right? So basically what's happening is that your body is hyperventilating, getting rid of all of that CO2 because of that gas exchange. It's all coming out. So for the causes, okay, sorry, I had to cough for a little second. Okay, so for respiratory alkalosis, you're having hyperventilation, meaning you're getting rid of all that CO2. So when it talks about pulmonary injury, so pulmonary insults, right? That's what it means, injury. When we're talking about pneumonia and mild asthma attack, acute is what we're talking about. Because keep in mind, like at first, you're gonna be like, if I were to think about it, if I had an asthma attack, at first you're going to be, and I would almost think about it like, um, an allergic reaction, right? Let's say I'm allergic to peanuts. I eat a PB and J, and now I'm having an allergic reaction. My throat's swelling up. I'm going to be breathing as fast as I can because I know my throat is swelling up and my body's going to try to breathe as much as I can, right? Like, and then eventually what's going to happen to your vessels, and we know that with an allergic reaction, your vessels and your specifically not your vessels, your airway is going to close. So it's going to constrict and eventually it's going to close all the way, which is not a good thing. So if it's closing, eventually I'm going to be hypoventilating, which means I will go from respiratory alkalosis, right? Meaning that I am having excretion of CO2, I am hyperventilating, to respiratory acidosis, where I am now having higher CO2 levels because I am hypoventilating because now my airway is closed. So I would just think about it like an acute setting. You're going to be, your body's going to be reacting, like trying to get as much air as possible. That's why with pneumonia, like you can see them having an alkalotic state because they're going to be trying to get as much air as they can. But then eventually, once it's become more of a chronic thing, or after a while, it's like, okay, I'm going to be hypoventilating because my body doesn't necessarily need to work. It needs to calm down, not work as hard. Or your body's getting tired and like we're kind of giving up. So that's why it says those. So say acute is the main thing with those things. And then it's the same thing, like it says early salicylic intoxication. So eventually, like even with an opioid like overdose, that's more of a metabolic thing. But if we were talking about like what you're gonna see with the respiratory signs and symptoms, like a first you might be like hyperventilating and then you're gonna be hypoventilating. But again, focus on what is affecting the pH. So even I can get off track when it comes to that stuff as well. So hyperventilation, so anxiety, that's a big one. Anxiety attacks, fear, stimulant drugs, so like meth, anything like that can make you go crazy. Pain, sepsis is another cause, and it does go into respiratory alkalosis, and that's why I think some people got confused on the exam because they were like, this is what, like, we have proof that it says sepsis. And so actually, maybe I should show some of my friends this because they were going to argue with my professor that they saw this. But what is causing the respiratory alkalosis to occur, right? So if this is a question, like focus on like the metabolic, basically it's a metabolic issue, but basically what's happening is that your compensation is respiratory alkalosis. So even though it says that, and that was one of the causes, and I think that might have been there for second semester, I would also just know that's more of the compensation method with that. And then basically, I can't say the word, hypobarism, high altitudes, right? So it's harder to necessarily breathe. So as a compensation response for your body, you're going to be hyperventilating. And I shouldn't say like compensation method, but like basically because like you're not able to get as much air when you're at, like if I was on Mount Everest, I'm gonna be like, I would also think about it like if I'm getting all the way up there, I worked hard, so I'm gonna be breathing harder and faster. So yeah, you can breathe into a paper bag because again, you're getting rid of all that CO2. So if I'm in a paper bag, all that CO2 is staying there, right? And it's able to just come back in when I'm inhaling. And then again, you can give IV chloride containing solution because now those ions are replacing, the chloride is basically replacing lost bicarb. So with this, you're going to be seeing 7.45. So this is going to be in an alkalotic state. I don't want that anymore. So we're going to be seeing the CO2 down, which means we're also in an alkalotic state because CO2 is an acid. So for the bicarb, would we want that high or low? So answer that. Okay, so with HCO3, we know that it's a base and we know we're in an alkalotic state. So we'd want a further alkalotic state or an acidic state. We would want an acidic state, right? So we know that HCO3 is a base, we know that it's alkalotic state. Basically, we would want less HCO3. So basically, our kidneys would want to excrete more of that bicarb than retain it, right? So it would be probably like below what 22, so it could be like 18 or something like that. So then I would look at it. So now it's in an acidic state, technically, or trying to become more in an acid state. So it's going to drive the pH to be able to come back down to a more of a neutral by making it a little bit more acidic. So it's going to be partially compensated because this is going without out of normal range, but this is still driving the pH to be alkalotic, so respiratory alkalosis. Hope that makes sense for everything right there. So again, fully compensated, the pH is returned to within the normal limits range, but the other values can still be affected. Partially compensated, the other system is now affected, but that doesn't mean the pH is fully corrected yet because the body hasn't compensated and dealt with the other system also going out of range as well. It takes a little bit of time to do that. And then you have uncompensated, nothing has happened. That's still first and second semester stuff. And we don't want that. So for this stuff right here, I'm not going to harp on this because this was more for like the quiz. So if you're having difficulty with that, go back to the video from last week. There's the information I sent to you guys for the email for that. For renal people, Harding, since I know she quizzes over that stuff, go ahead and try to study this raw system. There's a question about it. I'm gonna mention it just because I don't remember what the other ones were, but I did know that this was the answer because I was like, I don't remember this being a part of it. So if it doesn't look familiar, then don't click it, right? So I'll go through that in a second. For IV solutions, this was okay, guys, so it's the next day. So I ended up having to stop recording because I just wasn't really feeling well and I just cut myself off and just I'm gonna try to put these two videos together. But basically the raw system, we'll go over that. Or I would say I'm not gonna go over it, but you should go over it, but I'll just tell you kind of a similar question that she would kind of ask for the quiz because it is a part of the renal system. So for IV fluids, really we're talking about isotonic, hypotonic, and hypertonic solutions. It's just knowing what they are. So those examples there with like normal saline 0.9, anything less than that, anything more than that. So hypotonic, it's less concentrated than the blood, so the water is pulled from the blood vessel, so in that intravascular space, into that intracellular space. Whereas with hypertonic, we're talking about there's a higher concentration in the cells than the blood. So water is pulled from the cells out to those blood vessels. So basically with hypotonic, the only thing you really have to be worried about is that can cause those cells to burst. Whereas with hypertonic, really, we're just going to be worried about those cells shrinking. And since all of that fluid's moving out, basically you're worried about edema, right? Because all of that fluid's going into that intravascular space. So with IV accesses, I'm not really going to go over this that much either, just because I feel like they didn't ask us that much. It's just knowing some of the differences between the pros and the cons, I think. So with peripheral lines, this is obviously the ones that we do in clinic. You're inserting them peripherally. They're very far from the central vein. Whereas a midline access device, there's a catheter inserted midway, but it's still smaller than a peripheral, and it's still, or it's bigger than the peripheral, but it's still smaller than a central line. So it is inserted with ultrasounded guided venipuncture. So there's a lower risk of bloodstream infections and occlusions than a PIC, just because there's more of flushing that we have to do with a PIC, which is a central line. There's more of an infection process that we have to do, just because again we're going more in. It's a little bit more invasive than a midline. So it is staying for weeks. It's also another long-term treatment, but most of these like midline, central lines are going to be. So avoid with history of thrombosis, hypercoagulability, decreased venous flow to the extremities, or end-stage renal disease requiring vein prevention. So again, I'm just kind of reading it because I don't think that they'll ask that many questions about it. This is kind of what a midline looks like. So not all the way to a central vein, but it is going midway through. So central line, this is a longer IV, so definitely larger than a peripheral, definitely larger than a midline. It is a longer IV that goes to a central vein. So this includes the internal jugular veins, the femoral veins, subclavian veins, which are bigger veins that we see. It essentially enters into the tip of the right atrium, so kind of right next to the heart. And it reduces damage to small peripheral veins, and that's because we're giving vesicant medications and we don't want those veins to end up getting damaged long term. So as well, we also want to have it for long-term placement, just because if we're talking about cancer patients who have to get chemo, we don't want them to keep getting poked with our IVs and everything, because that's going to get super annoying, in my opinion. So basically, we can administer crystalloids, so IV fluids, colloids, so proteins, dialysis, blood, vesicant medications, and remember that means high concentrated like chemo medications, and nutrition like TPN. So a triple lumen catheter, that's just basically where it allows for multiple IV drips simultaneously. It's always going to be placed by a physician, and it's just, again, in ICU settings, emergency settings, you can have it for dialysis, and we'll talk about some of that stuff. So let me see here. So this is a triple lumen all the way to the side right here. So it has 3 different lumens right there, whereas a single lumen, and I think we were talking about this in class the other day, it makes more sense to get a triple than to get a single lumen, just because you're able to do more. So it kind of doesn't really, but of course, it might just be up to the provider and the patient in terms of what they do need. So a portacap, this is also a different type of central device, but it is mainly seen in cancer patients, especially with people who want to have a certain type of lifestyle that is still similar to how they were before, because you're actually going to be placing this in and you're just going to be able to feel it like nothing's poking out. So a Hickman, Broviac, Rochon, and then Ash and Vass, those are all tunneled catheters, and we'll talk about that in a second. Whereas this one's a surgical, like in-placed portacath, but these are just PICC lines, which are tunneled catheters, or non-tunneled, excuse me. So PICC line is a type of central line that's non-tunneled catheter that is entered into a peripheral vein, then threaded so its tip is in its position in a central vein. So it's best suited for long-term treatment lasting several weeks to 6 months. Short version of PICC, known as a midline, the tip of the catheter, does not end up in a larger central vein as a standard PICC line. So I think that makes sense because we talked about midlines, right? So blood drawing shortens the service interval of the PICC, and that also kind of is similar to a portacap. You can only do like 2,000 punctures with it because you're going to shorten the service. It's kind of just like how we have to eventually put in new IV tubing, put in new IVs. We have to be switching that out every so often because, again, we don't want any damage to those veins. We also just don't want them to be more at risk for any types of infection, any types of emboluses, or anything like that. But it's just saying that a blood draw basically shortens the service of that PICC. So with dual lumen lines, with a 2 lumen line, a large lumen should be used for sampling as well. So pros of a PICC line is basically it's only slightly more invasive, easily inserted and removed, it's inexpensive, and complications are rare. So when we talk about those complications, which are down here, it's a little bit more rare for those PICC lines. For cons, it is high maintenance, so it requires daily flushing because, again, we don't want any clots or we don't want any air emboluses or anything. It often migrates, so obviously because there's a section that's out of the skin, like with this PICC line right here, like there's still a section that's out, and especially if there's those triple lumens, kids, they can get tripped up in terms of like if we're changing a patient, if we're moving them around, we're always like worried about where their IV is at and fixing it for them. But obviously you have to worry about that because it's in the central vein, but they can move around. So you just want to be able to know, like, is it still in the right location? We're not pulling it out, nothing like that. So limits lifestyle. So again, like you do have to make sure that you're giving your patient like, hey, do you want to wear a bag? Like you can't really be swimming, anything like that. So that's why sometimes people prefer a portacath if they're getting a longer term treatment. So it's best suited for treatment lasting several weeks to 6 months, which again, all of these are going to be more long-term treatments. So with portacath, this is plastic or metal housing placed under the skin and connected to a vein via a tube. The port is a silicone disc that can withstand 2,000 punctures. So that's why you see, like, again, you don't want to shorten the service by doing more, or then a single or dual lumen. So it can be more with that as well. And that's what a portacath looks like. So you'll be able to feel it. it's under the actual skin. So that's why it's saying like these are all under, like you're not seeing anything poking out, but you'll be able to feel it. And then all you do is you feel that whole entire circle, and then you're just going to poke in the middle. And you will not miss it. Because I feel like that is a fear that some people have, but you'll feel the whole circle and just aim for the middle of that. And so the pros of that, it has least maintenance, so you don't necessarily have to, you don't have to flush it, right? Because you're going to be poking it. And it has its special own required needle and everything that goes with that when you're giving medications and trying to access that. Um, so again, like they're allowed to kind of be more able to swim, shower is easier. They don't have to worry about more of that maintenance and worried about taking care of it. So with good for long-term access, more than 6 months, so it is a little bit longer than and more recommended than a PICC line. So that is something to note. And again, it's more associated with cancer patients because of the chemo. Some cons is that it's a more costly device, again, because it's more time consuming to implant and remove. So it's an actual surgery and it's going underneath that skin. So tunneled catheters, so that's going to be all of those ones we talked about at the top. So a Hickman, Brobiac, Rochon's, I don't know if I'm saying that right, and Ash and Avast. Specifically, the Ash and the Avast are the dialysis catheters, but they still are tunneled. So when we say non-tunneled and tunneled just meaning it's tunneled through the skin first, and then it's entered into a central vein, whereas, because it's still a central line, but the other PICC lines on the top, so a triple and a single, that's peripherally inserted into a central vein. So as you see, like right here, you have all of this space and it's in red. It's all inserted into a central vein right here, but with the PICC line, we kind of just have a little bit of space that's poked out of it. And then with a tunneled catheter, you're gonna see like this this is the Broviac. It's a pediatric catheter. This is all tunneled into the skin first, and then it's inserted into the vessel. So it's under the skin, but not directly in the vessel like a PICC line is. So a tunneled catheter, it could be a single or dual lumen as well. It's inserted by a tunnel made under the skin between the port and the vein. So basically, there's a little bit more separation between the insertion point than a PICC line. And then it's used with frequent access. There's high flow infusion that can be given, infusion of blood products, dialysis, so the ASH or VASCATH. It's an intermediate or long-term use, and then there's lower risk of infection. So dialysis catheters, 2 lumens, one for blood withdrawal and one for the return of dialyzed blood. So there's usually 2 tubes in 1 lumen, right? I just said that right now. Arteries, one's of them for the artery, the other one's for the vein. Arteries go away, remember A for A, and then the veins just go back. So permanent ash cath, and I know Harding uses like I think her dog for like the story for that. So yeah, ash cath and then tessio cath and then a vast cath is the temporary one. And the way that I think about it is a little bit nerdy, but like watching Pokemon as a kid, there's a character named Ash, so it's like it's permanently in my mind because I watched it as a kid. And then complications of central lines, so PICC lines, it's a little bit more rare to get these, right? So sepsis, right? We're doing any type of surgery, we're inserting any type of thing, even with a peripheral line, we're still worried about bacteria if we're not having aseptic technique or anything. So basically, pneumothorax is another thing. You can puncture the lung. Hemothorax, you can puncture blood vessels, and then basically that blood goes into the pleural space. Mediastinal hemorrhage, same thing. You're going to be inserting a central line, but you end up poking or hurting the mediastinum. Air embolisms, right? So air enters that bloodstream through a central line, or you're not, or you're let's say you're not ejecting that air out of your flushes or anything like that. Arterial injuries, you're worried about injuring nearby arteries when inserting in the central line. Wound dehiscence, so separation of edges, so that's why we're just making sure we're having proper site care. So you want to be changing them. Dialysis catheter sites usually are going to be cared for the hemodialysis nurse, but you're going to be collaborating with them on that. And again, I don't think they asked that much about it. I have it highlighted, but she didn't ask us anything. I think the only thing she might have asked was document date and time changing the dressing site. So just make sure you're not doing opinions, like you're not saying anything that is opinionated, that doesn't have facts behind it, right? So they're able to tolerate the procedure. IV site observations, like are they having any signs of infiltration? Are you checking that? Are they having any signs of infection? Is it hot? Are they getting a fever? Or is it red? Is it swollen? And then the condition of the skin, obviously, like how is it looking? Is there any drainage? And then you note those specific things. So again, you don't want to be giving subjective information. You want to be giving objective. So they're not opinionated, they're actual facts. So with the difference between parenteral nutrition and parenteral, we're just talking about bypassing the GI tract entirely. I don't want it. Just give it straight in the IV. For enteral, we're talking about they're still going through the GI tract. So we're talking about NG tubes, gastrotomy tubes, I just say JJ tubes. So IVs nutrition that can be made up of amino acids, carbs, so D5W, which turns into glucose and helps with the sugars, fats, electrolytes, vitamins, minerals. So when diet and enteral feeds can't provide enough nutrition, we can also go ahead and give them IV nutrition, and it can be given peripherally, so PPN and usually associated with peripheral lines, or TPN, which we should be giving through a central line. So TPN, this is more specific to the patient's needs, so it's adjusted to whatever they need, and the pharmacy, they're going to be able to figure out what exactly they need, and be able to have it and give it to that patient. So you're going to use an IV pump. There's a micron filter that you're going to use. The biggest thing we're just worried about with TPN, that they might have hypoglycemia, right? So you're going to monitor those blood glucose levels, because again, we're having those carbs in there. So basically, if they are becoming hypoglycemic, or let's say you're watching for your cracked TPN, if you see that the TPN's cracked, that's not a good thing. That means you have to call pharmacy. They got to get a new bag. Maybe it's expired. Maybe something's going on with the TPN, but you're not going to give it. During that time, you should be hanging 10 to 20 is just what I think the book recommended, dextrose solution, when the TPN is not available. So you're going to be giving them that, and then you're going to be monitoring their blood glucose levels. You're going to change the tubing and bag every 24 hours. And then again, you're going to discontinue that gradually, because you don't want to have them become hypoglycemic right away. So PPN, it's not patient specific. And basically all that it is, I'm not going to read it, but it literally is just support and supplementation. So it's not as specific, but it's just if a patient needs that, it's support for that. Just further support. So lipids, you can also go ahead and give this with PPN and TPN. It's just fat emulsions. And so one big thing is just make sure they're not allergic to soybeans, sunflower, or eggs, given intermittently, because again, just like how with TPN, we're worried about hypoglycemia, we don't want them to have hyperlipidemia if we're going to be giving that like bolus. So we need to be giving it every so often. So infusing and the same times changing every 24 hours. And so then you have this picture right here that kind of just going through the pump as well. So with the renal system, I'm not going to go over this. I'm just going to tell you guys kind of what I would recommend. I remember this a lot more whenever I went through it, and I felt like reading the chapter for the A&P actually was super helpful. And I felt like a majority of her quiz was A&P, so I would recommend, if you have time, to probably read some of the book. But this does go in this information as well, so I would also take a look at this. But yeah, if you're just wanting to like see what's possibly more on the quiz, and again, that can change from each semester, but I know she focused on this, knowing what the kidney functions were. I know she had asked us one of the A&Ps for this system right here, so just knowing what these three things are, and especially with the tubular system, there's like a little acronym, but I don't think she had asked us about that specifically, but I know it was something along this way and was just an A&P question. This is just talking about the blood supply. Afferent, the direct blood flow goes to the glomeruli, and then efferent, they're transporting blood away. That's just something to note, but she never asked us about that, but I thought that she would. And then I feel like she didn't ask about any of that stuff, and it really is just kind of things that you're more of, I think, are common sense. With the labs, I put like stars to it. I know that she's probably going to ask about BUN, creatinine ratio, EGFR, and then maybe creatinine clearance as well. But really, she has a document, and I think I might have just copied and pasted some of the stuff on here. So again, like read this information, go through it. But I probably won't today, and I will try to go through this information next time with you guys, if hopefully the time allows us to, because I know that it is a lot. So in terms of, I'm going to stop sharing for a second. So in terms of what's to know for the quiz, um, let me go ahead and see what she had asked us similarly. And so I was looking it up, some of the things, because I was like, what are some questions that she could ask about this? So let me see really quickly. I'm going to pause really quick. Okay, so basically, she had just asked us the RAS system, kind of the processes within that, and just making sure you know that it increases blood pressure, but like the steps through that. So if you see something that isn't one of the steps, then don't select it, right? So just make sure you're going over that. Another thing she had asked us was like the BUN and creatinine ratio. So BUN and creatinine are just waste products. So if the kidneys are able to excrete that, that's what we want. So if we have a higher level, that basically means the kidneys aren't excreting that because there's more of that in our blood because they're still holding on to that, they're not excreting that. So that basically tells us how well our kidney function is working. Because again, with knowing what those functions are of the urinary and renal system, because you do need to know that, that is another quiz thing. It gets rid of waste products, right? So basically, if a patient misses dialysis, okay, so meaning that they're not, basically dialysis works as their kidneys to be able to filter those waste products out. So if they miss dialysis, um, basically what would you expect their BUN and creatinine ratio to be? So would you expect it to be higher? Would you expect it to be lower? So that is just something to think about. I will say that whenever you're, I feel like I'm going to give the answer, but when a patient is dehydrated, so you're going to see the BUN and creatinine ratio be higher. Whereas if they aren't dehydrated, if they're overhydrated, meaning that they're holding on to more fluid, and remember they miss dialysis, and again that's to help us with our fluid balance and to help get rid of those waste products. What would you expect their BUN and creatinine ratio to be? So I hope that kind of answers the question right here. So dry is high, but for the opposite, so if you have too much fluid, you would be low, right? So that should make things a little bit clearer. And then, yeah, just knowing some of the nephroscopic ANP, so that glomeruli, that Bowman's capsule, and then the process for that whole entire tubular system. So Peter listens during church. And then basically, again, then I think she had two questions around the raw system. So just knowing that. Let's see here. What is EGFR? So basically, what is EGFR? Just knowing that it is, so BUN and creatinine are waste products, and so we are able to know our kidney function by those waste products. And then additionally, which one is better? So creatinine tells us of a better standard. And from looking it up, because I was like, why is creatinine better? I literally just looked it up, and Google has like a new AI like overview. Basically from what I remember it saying is that it just tells us better than BUN, just because it is more stable and it is affected by many factors like diet, dehydration, whereas creatinine is more stable and removed from the body at a constant rate by the kidney. So I would just say either way, creatinine is just better according to some studies. So yeah, other than that, EGFR tells you the glomerular filtration rate. That's literally what it stands for. So just make sure you know the differences between those two. And then what are some medications that can be nephrotoxic? That's just something that you should know. So even if a patient is going to what is our biggest like diagnostic worry that we're always talking about? Well, yeah, like if they're going to be getting contrast, we're worried about them getting that contrast, and if they have metformin on them, right, because it is nephrotoxic. We don't want to not educate our patients about that. That is something that we talk about literally almost every single time. So there's just something to know. So let's see here. I think
other than that, that's pretty much it. Let's see here. I'm gonna try to look up something really quickly. Other medications you can be worried about for your kidneys. So obviously we know NSAIDs. It says aminoglycoside antibiotics, but I feel like again, like all antibiotics kind of are just terrible for your kidneys and for your liver. Um, Diuretics can eventually affect your kidneys, so you are worried about that. Chemotherapy agents, which we know make sense. Antivirals, again, kind of similar to antibiotics. But yes, so I would say NSAIDs is definitely a big one, as well as any really antibiotic can be very effective um, to your kidneys. And then again, with metformin and with like MRI contrast, we're worried about that. We're educating our patients on that. But other than that, I think that's pretty much it. So I hope that kind of helps you guys at least to kind of summarize. But I would definitely try to read that section of the book because I do feel like it helped me with my quiz for that. And then hopefully to the rest of you guys, I was able to help out with that. I know I'm kind of just out of it, and hopefully I'm able to help you guys better for your exam next week, which I well, hopefully if I don't do a session, I definitely will just try to send out a Kahoot or a document to you guys. But other than that, have a good day, guys, and then good luck. Let me know if you need anything.